Prof. Eddie, interview, take one.
Okay, Prof. So please introduce yourself by telling us who you are, where you're from, and what your title, your job title is, and what that entails.
Hello, greetings. I'm Professor Eddie Mhlanga. I don't know exactly where I'm from. I'm from all over South Africa, but I'm staying in Pretoria now, but born in Acornhoek, the Bushbuckridge area. But I've been fortunate to be all over the place. As an obstetrician, gynecologist, professor in obstetrics and gynecology, as a program manager in the National Department of Health, and also as a provincial specialist in Mhlanga for the last, I think, 4 or 5 years. I've been in Mhlanga. So that's what Eddie is all about.
Great. And so what have you been busy with in the last couple of months, in the last 6 to 8 months?
Well, I have been a provincial specialist in Mhlanga, and then went on to be supporting 2 hospitals, mostly 2 hospitals out in area close to Pretoria. That's Mhlanga Hospital as well as Mhlanga Hospital. There I would support particularly the TOP clinic, or sexual and reproductive health clinic, where we would offer second trimester terminations of pregnancy, as well as contraceptives and any other women-related services, including forensics, recording issues of rape, and working together with social workers and the police. Since the end of November, when I turned 68, Mhlanga said, well, you're old, we're not going to renew your contract. And so I waited, hoping that they probably will say you can still come back and offer some services, because Mhlanga has got very few specialists, basically no support for district hospitals, even the specialist hospitals, the referral hospitals. Sometimes they don't have specialists. So I had hoped that that would be part of my work as I retire from the service. I haven't had any word about that retirement or the job that they would like me to continue to do. I've offered, though, that if they've got any problems, which the doctors do utilize, that if they've got any problems, they can phone me for advice for whatever, if they are running into problems. The professional nurse out in Mhlanga also, if she's got any problems, then she calls. So I will go out and volunteer to do and support her, particularly second trimester abortion, because in the hospital no one is prepared to do it. At the National Department of Health, I've been asked to be the chair of the National Committee on the Confidential Inquiries into Maternal Deaths. And that's a committee that I helped set up way back 1996-97, the National Department of Health, to look at why women are dying. I think that is an important job to do. However, we think that we should be doing a little bit more to actually go to the facilities, to interview people who were looking after these women who have died, to really find out the reasons for women losing their lives. And unfortunately, we do see steady increase again of women dying from unsafe abortion. And I think we need to rejuvenate that. I hope to work with also other organizations, really in advocacy, to again challenge the politicians, the communities, the doctors, and the policymakers to rise up to this great need. The law is there, but we not. There's no one who actually says, yes, I am taking the issues of women's dilemma, the challenges that they face, taking it forward, taking it to Parliament, mobilizing parliamentarians, and so on. So that is the kind of work I hope to be doing on the sides, going back to 1996 when the law was passed.
And what is this need? What are these issues that you are trying to get people to rise up to? So the question is essentially, what are the core challenges, particularly in access to abortion services and other sexual and reproductive health services? And has COVID-19 exacerbated those challenges in any way?
The challenges for women is that in South Africa, we do not have many people who are taking issues of women's health to heart. Now, women's health is different from obstetrics, midwifery, and gynecology. They're much wider. The issues of abuse, we have talked about gender-based violence, spousal abuse, neglect, the whole issue of discrimination against women. We've got CEDAW, the Convention on the Elimination of All Forms of Discrimination against Women. It was talked about in the 90s. Today, as we're sitting here, there's hardly anything that is done about that. All those issues then come into women's health. Issues of mental health, depression, anxiety. We know it is endemic really amongst the women who have to juggle various things to try and keep a family together. So those are some of the challenges, apart from the fact that women still depend on men for their resources to be able to access services. Some of the sexual and reproductive health services, like contraception and so on, men still can say, no, the contraceptives make me weak, therefore don't use them. Things like that, and the woman will not, particularly in the rural areas. So those are some of the challenges. The wider, more concerning challenge is that as government, we have not made sure that the people we employ feel they've got a responsibility of providing the service to women. So women continue in South Africa to be treated as second-class citizens. And that's the sad thing about it. And of course, the COVID thing just highlighted the depth of the problem. You find women in some hospitals lying 2, 3 to 1 bed, and these women are in labor. One may be the fluid is already coming out, the other one is bleeding, but they have to share a bed. And we don't even talk about privacy, we don't talk about cross-infection, okay? But no, it's as if everything is fine in South Africa. How do we justify this? Now, of course, COVID came. There were no separate facilities. For those who come in with, who are infected, who have to go to theater, because there's only one theater. And if you're going to close that one theater and say, well, I'm going to fumigate and stuff like that, what about the next one who needs to come in? And we see sometimes women sitting for 2 days, 3 days, waiting for COVID results whilst they are bleeding and whilst infection, the risk of infection is now increasing. Okay. So these are some of the challenges. The whole issue of the PPEs. The last people in any hospital who got PPEs were the people working in maternity, in women's health. Okay. And is it because most of those people who are working there are women, therefore they are second-class kind of healthcare workers, but the ones who are working where people come in having been beaten on the heads and they are bleeding, those get the PPEs. But those women are also looking after other women in the maternity section. So therefore, the second-class health workers are looking after second or third-class patients. And that goes on. And unfortunately, I think that it may even be that the leadership in women's health is mostly in the hands of men. and therefore the empathy is not there. I think right from national. Hopefully with the new administration we'll see some difference, but certainly the past minister has not done anything to promote women's health. If anything, it was like they can be used for a particular end, but not for their rights as people. So COVID has come. Often people come in, they probably contract it in a hospital, and then they go home, and no one really follows up. Issues of ambulances. You call for an ambulance because a woman is bleeding. Maybe she has had an abortion, or whether maybe she's in labor. It will take 2, 3 hours, 4 hours in some provinces before an ambulance comes. But if you say somebody has been stabbed on the head, not even in the stomach, to say he's bleeding, the ambulance will come in there, and then they say, oh, please, can you also go past such a clinic? There's a woman in labor who needs to go to hospital. Okay. So the support structure also is really not there for women. In some referral hospital, women stay for 2, 3 days having been admitted. They've got an incomplete abortion, but there is no space in theater because there's only one space. So a person comes in on a Friday, bleeding, they've had an abortion, it's incomplete, they wait until Monday. By that time, infection has set in, and really the future of that woman is very questionable in terms of their reproductive capabilities. So these are some of the things. Of course, COVID then came. Suddenly, COVID is the thing. The others can wait, almost like the problems of women then disappear. Then we see the issues of gender-based violence, the rapes, the intimate partner violence within the closed space. And then women not being able to go out to fetch, to access abortion services. Where do they go? They don't have the permission, the police stop them. They cannot tell the husband or the boyfriend that they're going to terminate the pregnancy. They get to the hospital says, sorry, the abortion is not an emergency. Okay, so we're dealing with COVID. So that one is part of the elective bill. Now, not only for abortion, even for women, I know I lost one patient who had become a friend from cancer of the cervix, and she was only 36. Okay, she died because the one hospital kept on pushing her off in Gauteng. Ultimately, one had to call the head of department in the tertiary hospital and say, please, I beg you, so on. And that is how ultimately she got help, but it was too late. The cancer had already spread to stage 4, and then about 2 months ago, she passed away. So this is the lot of the women in South Africa. So although the policies are fine, the reality for many of them is that still the backstreet abortion is the only relief that they can have.
So sorry about your friend, Prof. And you obviously mentioned that these issues date back to the 90s. Of course, COVID has added a whole other layer. But what opportunities do you think exist now that probably did not necessarily exist then, that especially younger people can just use and really strategize around with people like yourself, on an advisory level? What opportunities are there right now in terms of resources and people that we can use or try to maximize on to address these issues?
I think the opportunities of really canvassing for people who are taking the issues of women's health to heart, to actually pass on the knowledge, but also the support to them. To say, yes, I'm around, yes, we can organize a certain number of people who will be a backup. So not only for the doctors, but also for your clinical associates, as well as the nurses who have to be trained. I think that's an important thing. Unfortunately, or particularly because South Africa doesn't seem to have a, what do they call it? Succession plans. South Africa doesn't seem to think that is important in any way. So when retirement age comes, they say thank you. If you are lucky, they say thank you. They never said that anyway to me. It was just like it's out of the system. People still today think that I'm still in the department. But that's succession planning, and I think that it is important to encourage government to start engaging in this forward planning and saying what resources do we need for the future, and how can we use the current resources that we have, even if they're retired, they haven't retired in their minds, and then they can contribute to that planning forward. And then non-governmental organizations like our equity and so on can also come in and say, yes, we identify certain people, but can we have other people to come in to support this? Most people do not really look for money. They just look for opportunity and just facilitation to be able to say, yes, we're passing on. The greatest joy that many of those who are retired have is to see the skills, the younger people coming up and taking, that activism and the energy that they bring in, and so on. And then, of course, other things that make things a little bit easier now is, for instance, the availability of medication, for instance, termination of pregnancy. And of course, this has been accelerated by the COVID, because now you can do the whole process. People can do it at home, and then they only come in once, and if there's a need for surgical intervention, then that gets done. But the rest of the process has been done outside the hospital. And then when they come in, they don't even need to sleep in hospital. And the other day, we had a lady who's about 20 weeks pregnant, 14-year-old, started the process at home, and then in the morning of now the procedure, started the procedure in the morning, gave her the tablets. By 4 o'clock in the afternoon, she had miscarried and put in an intrauterine contraceptive device. Then she went home. And the past 2 days they've been saying, no, we are all fine. That lady is fine. She was only 14 years. So the mother said, no, she's fine. Everything is fine. So those are some of the innovations now that come in because COVID has come in, but actually now opens our eyes that some long-held beliefs that, second trimester, you must admit them into hospital. So if you don't have enough beds, therefore, the others have to wait. No, you can do 4, 5, 6 patients in a day on an outpatient basis, and nothing. There's no need to hospitalize. However, anyway, you still need to make the allowance that in case they have to be admitted. But we do that with any patient anyway. If they've been injured and we think they can go home, that's fine. But if we find that they're injured but they cannot go home, then we admit them. Because termination of pregnancy is like any other procedure that people come to a hospital for.
Nice. So you were invited to a retreat to come and relax and walk barefoot. Do you think this is a necessary space for people who do this work, such as yourself, who've been doing this work or who are doing this work? Is it a necessary space to have such?
I think it's indispensable. When I was still at the National Department of Health, we actually advocated for such, a retreat, for de-stressing and so on an annual basis. However, because again of the challenges that we have in terms of leadership and so on. Some people don't think that it is necessary. Unfortunately, those people are people in the decision-making levels, up on top. But as they would treat issues of women anyway. And it's even more important because many managers within hospitals do not appreciate the emotional and psychological investment that the abortion providers actually make, far beyond what the salary compensates them for. Some have paid for the work that they're doing with broken marriages because they are always responding to crises, the stigma within societies. Some have actually, we have lost quite a few who have died, again because of the stress, the hypertension, and so on, and there is nothing to help them to distress. So this is, it's very, very important. I cannot stress that enough. Just for the providers to come together, to share and hear stories. And this weekend I've had stories that when I think back, I said, but how did I get over that? Why did I not face those? But maybe I faced them, but my position tended to protect me somewhat from the abuse and the stigma. I know that within the church I was told that, this is the one who's killing babies and things like that. But I made no apologies for that. I said, well, the Lord will help you one day so that you can respond to the needs that you see. This is the best way that I can. If I'm sinning, may the Lord forgive me. But may the Lord bless you, who's got no sin on your hands. Okay. So that's so that is my way of coping. But others do not necessarily have that because people will be speaking behind their backs, or they suddenly will be distancing themselves from them, and you find that they are isolated within communities. So it is indispensable, I think. Other countries as well need to look at this. Abortion care is a service of love, not because there's anything that one is going to get out of it, but it's of love and saying, I would like this life to be protected so that she has another chance. After all, God gives us another chance.
Absolutely, Prof. Perfectly. What's your most memorable experience actually for the last couple of days?
I think I would say the most memorable, because everything that has happened over this weekend has been very memorable. From yesterday morning's session and looking into ourselves throughout to the sharing that happened yesterday in the morning. I was really touched by for instance, Dudu say, I want to go home. And this is a cry that most abortion providers would say. I wish when I go off from work, I could go home, where there's warmth, where there's acceptance, where I know I've got my roots. That was very, very challenging. And the other one who said, because of my experience, I'm dead. I'm dead inside. And it really opened my eyes to the depth to which the lack of support can push people. But they still wake up in the morning and says, I'll go, I will serve again. Okay? And then again this morning's, or yesterday's, I mustn't forget that the massage. I've never had a massage in my life. Okay, right, and suddenly, when you get your feet washed, then I understand the work that the Lord Jesus Christ did, washing his disciples' feet. you know, there's something in that that says, I care for you right where you're connected to earth. So I'm caring for you. So I had that wonderful one. After that, I couldn't concentrate on anything. I tried to do some bit of work. The brain couldn't, because it was in such a mode of relaxation. And I think that was very very important. And then today the issues of you know uh, mindfulness, silence, reconnecting. Uh, those are exercises that will help us a lot in coping with the challenges, not only in abortion care, but other challenges with certain victims of violence, trafficking, and so on. You are able to then de-stress the coping mechanism. So these have been memorable. Of course, the setting itself is out of this world, and I just want to express my thanks. I hope I can communicate and transfer some of these things. I may transfer the environment, but maybe I've learned that in any environment you can find beauty. Even in the most arid of areas, you can find beauty when you look for beauty and you are calm within yourself. Now, in terms of what I would now say to younger people and other people, the young at heart and also young in body, to say to them, when you serve other people, you are serving yourself. And therefore, do not give up. The tree that has got the deepest roots is the tree that gets blown most by the wind. So, as those tempests come, the storms come, hold on, because the woman's right is your mother's right. Your mother's right is your right, because without her, you would have no right. And we like to say, hope that people can look and see other women, other beings, as creatures who are created in the image of God. And no one chooses to be in a difficult situation. But we are chosen to be in that space to provide the necessary care that God's angels would otherwise have to do. Thank you.
Thank you very much, Prof.